All right, here we go. So the neurology highlights for acute care NP. Um, Goals and objectives are before you. Yes, this slide is wordy. Basically, building upon the information that you have in the course material, as well as what your knowledge base is as nurses already. And the most important thing is learning how to manage highly acute illness and injury, as well as the exacerbation of the chronic conditions in the acute care setting as the acute care nurse practitioner. We're going to talk about headaches, delirium versus dementia, seizure disorders, CNS disorders such as meningitis and encephalitis, and then peripheral neuropathies, so Guillain-Barré, myasthenia gravis. And one thing that we won't cover, but will be covered in our separate lecture is spine and orthopedic related neurotrauma. That will be in a separate lecture series. So for the headache, did not realize this until, really, because not in a primary care clinic, but it ranks 9th among reasons for office visits. It's a very common reason to seek care. There are several different thought processes that go with the headache. Most recently, it's thought to be a secondary effect of cortical depression and neuropeptide release. So you have that synergistic effect going on. The neuronal depolarization occurs, and then that causes the peptides to release, which then causes nerve ganglion irritation, getting neurogenic inflammation, hence why oftentimes NSAIDs work well. And then you get a vasodilatory component. And it's when you have this constellation of symptoms, what the person experiences is the pain or the pressure. Some recent literature also suggests that the calcitonin gene related peptide is involved. A third of the patients with a brain tumor are going to present with a headache. So not every headache is a brain tumor, and oftentimes, especially if you're working in the ER, you're working in an urgent care environment, the worried well, they'll come in. Age of onset is 25 to 55. From a migrainous perspective, so for migraines, more women than men, but there used to be the claim that men did not get migraines, and that's been proven false. However, so if you were looking for a test item, if it were presented, if you're migrainous, think more women, but keep in mind that men do get migraines. Cluster headaches, however, the classic or typical person for the cluster headache is going to be a man who is in their middle aged. There's primary and secondary headaches. Primary, the incidence is about 90% versus 10% being secondary. Way I think about it is the primary, the headache is the problem itself. It's the reason the person is coming. So migraines, tension, cluster. Our secondary headache is those caused by exogenous source. So your mild TBI, your concussion, your head injury, infection. And as acute care nurse practitioners, oftentimes we're not necessarily dealing with concussions unless you're like on a trauma or a neuroservice, but we're often more, as a secondary approach, looking at those caused by infection or a vascular disorder, a space occupying lesion, aka mass. For the exam, this is one of those things, do as I say, not as I do, so a prompt evaluation and appropriate treatment. You want to do a complete neuro exam, and then a psychological exam, so screening for the stress level, as well as depression and anxiety. And another potential test question, if you were to see something in line of medical decision making, one of the big questions is, well, when do we get imaging? And by a show of hands, how many people think that you get an image or like CT, MRI for the first significant headache presentation? No history of a headache. Otherwise healthy. Vitally stable. No neurodeficits. Does that change anybody's? So you have to keep it in perspective. So if it's acute, if it's onset, if it's they're like, I was walking down the street and now I have this significant headache, it's something to consider. If they're coming to you and saying, I've had this headache, it's been pretty pronounced, I'm not being able to go to school or work, I would think, not necessarily needing to go get an image. But if they come in and say this is the worst headache of their life, or this is a profound onset, they were sitting on the corner minding their own business and they have this onset, then certain. I really don't think anyone's going to fault you if you were to get a headache early, image early. But the thing to keep on in the back of your mind is what I'm ordering, regardless of whatever the presenting complaint is, whatever I'm ordering, how is that going to change their management? If it's not going to change, then is the radiation exposure necessary? As far as the exam, of course, it goes without saying, a complete neuro exam, but I would also make sure that we're making sure we get vital signs. I mean, how many times have we seen somebody room a patient and they may not have complete vital signs or most recent vital signs? So you certainly want a blood pressure, because is this, indolent hypertension that's masquerading as something more? Um, Fundoscopic exam, I'll be honest with you, I've been doing this for 20 plus years. I've been a nurse practitioner for 13. I don't know if I could do a good fundoscopic exam. You don't do it often, when you're managing a service of 25 patients, you don't have the time. But, certainly if you're able to do a fundoscopic exam, a board question would be fundoscopic exam, because you're also looking in. So if you have an abnormal fundoscopic exam, what are you thinking that might be going on? What's that? So, so the interocular pressure, you know, certainly, is there some type of intracranial hypertension going on? Is there increased pressure? Um, Not everybody has a tono pen to check tonometry to do interocular pressure, but if you can and you think it's important, consider that. And then don't forget the spine. So I always, when I'm approaching the headache patient, I think, or the patient with the headache, I think of what's going on at the brain, what's going up in the forehead, the face, because some of these headaches can originate from TMJ. It can be musculoskeletal related. But if you're not getting anywhere, also make sure that you're getting the neuro or the cervical spine. How many people think that if you were to, Mr. Smith comes in, he's a 54-year-old gentleman, worst headache of his life. How many people want an MRI? How many people want a CAT scan? Is there any difference between the sensitivity between the CAT scan and the MRI in this particular case? How many say no? How many say yes? How many say I don't know? And that's a viable answer. CAT scan and MRI methods appear to be equally sensitive. Why would I do a CAT scan? I would do a CAT scan because it tends to be a little bit cheaper, more readily available. It's less intrusive. It's not the binging noise. You don't have to strip down and remove all metal from you to go to the CAT scanner. And it's good at looking at what I would consider raw data or a quick image. So we're looking to see, is there blood? Is there swelling? Is there a new mass? The MRI is going to give you more of a finer detail. Sometimes the MRI may follow on the heels of a CAT scan. Other times they just go with the CAT scan. But just keep in back of your mind from a sensitivity perspective, both the CAT scan and the MRI appear to be equally sensitive. And then sometimes don't forget the need to perform a lumbar puncture. So, particularly if you're dealing with cases where you're concerning for herniation and whatnot, I would grab the CAT scan prior to doing the lumbar puncture. Just don't be lulled by a false reassurance that the CAT scan is the end all be all. There is a small percentage of patients who have a normal CAT scan, but then have devastating consequences from the lumbar puncture. But oftentimes an LP is quite is tolerated well. When we talk about headaches and the primary type of headaches, this is a good slide to kind of focus on. I would break it up into three. You have your tension headaches, you have your migrainous headaches, and you have your cluster headaches. Once again, for those who may or may not have been here, the migraines typically affect women to men in a 3-to-1 distribution, and cluster headaches are more male to female in a 5-to-1 distribution. The cluster headache, the typical cluster headache patient has daily bouts of 1 to 2 attacks of relatively short duration, unilateral pain, and that's the key, unilateral pain for 8 to 10 weeks a year. But then this is also usually followed by a pain-free interval that averages a little less than 1 year. Your migraine is usually unilateral. It's throbbing and moderate to severe pain. Worsens with activity, and it can last days or hours to days. The typical constellation of symptoms: nausea, vomiting, phonophobia, so light and sound sensitivity. Often there's a family component, and there is oftentimes a substantial impact on daily life. And then for our attention, the difference between attention and the other two is attention headaches is typically a bilateral. It's a band-like, non-throbbing, mild pain lasting minutes to days, usually no associated symptoms. Impact on life is typically minimal. And the trigger or causative agents tend to be tension, anxiety. And tension headaches are slightly more common in women than in men. So if you were presented with a test question and you were talking about the epidemiologic distribution, women typically have more tension and migraine, men typically have more cluster. The other thing about cluster that I find interesting is they will also get this conjunctival involvement. So they'll get the tearing, they'll get that redness for injection. They can get some meiosis and ptosis as well as rhinorrhea, and all of those which are typically ipsilateral. So that's the reason taking a good history with your history and physical works. So for primary migraine diagnosis, pain is preceded by scintillating scotoma. Anybody know what that is? It's a spot of flickering light near the center of the visual field, which prevents vision within the scotoma area. And the affected area flickers, but it's not dark. And then it gradually expands outward from the initial spot. Vision remains normal beyond those borders. Also, the fortification spectra, or tachypopsia, which are bright, shimmering, jagged lines that can spread across the visual field. I've had patients explain it to it. It's like the cartoon lightning bolts. Uniformed light flashes, so they get that photophobia. And then they can get some hemiopsia geometric visual patterns. So they have visual field cuts where the defective vision or blindness in the half of the visual field. And believe it or not, sometimes they actually get some occasional hallucinations. You can have cranial nerve involvement, so you can have some somatosensory disturbance of the face. They'll tell you that, one part of the face doesn't feel like the other. They'll get the paresthesia, the numbness, the clumsiness. There's weakness in a circumscribed area, speech disturbance. For the cluster headache, once again, we're talking about severe unilateral or periorbital, supraorbital, or temporal pain lasting anywhere from 15 minutes to 3 hours, and at least one of the following on the side of the headache. So they have the reddened conjunctiva, they have the facial swelling, they have the tearing, they have the meiosis, they've got the nasal congestion, rhinorrhea, or they have Horner syndrome. Anybody know what Horner syndrome is? Has anyone diagnosed it or seen it? Does she? Very much so. So very classic. So yeah. So meiosis is the constriction of the pupil. A Horner syndrome, you have the ptosis of the eyelid, so that drooping of the eyelid. And then anhidrosis, which is a fancy term for saying the lack of sweating. Um, Danger signs, hint, hint. You may see this on an upcoming quiz or an exam. Danger signs in the headache patient. So systemic symptoms. So are there stroke-like symptoms? Are there neurological symptoms? Onset. Onset as far as timing of presentation, also onset of age. So while we're not pediatric focused, um, the other engines of the very young and the very old. And then previous headache history. So if there's fever, weight loss, or any other risk factors that would make a secondary headache a possibility, you need to be worrisome. That should go on your radar. So HIV, pregnancy, someone who's on chronic anticoagulation, neurologic signs and symptoms. If there's an impaired loss of consciousness, if they have the knuckle rigidity, if they have the palpable edema, and you'll know if they have palpable edema. They'll have that bogginess, they'll have that the pronounced, and any abnormal motor function. Now, as far as timing, and we kind of talked about this a little bit earlier with the CAT scan, if there's a thunderclap during exertion, classic presentation is middle-aged gentleman who is not in the best shape of health, is doing adult behaviors. During the process of doing said behaviors, has this thunderclap headache. Their partner becomes concerned, calls 911. What were you doing? They explain the story. Very classic. So it's that thunderclap is during that exertion that had that increased intracranial pressure. Onset age, more worrisome. If the headache, and key point on this, folks, is if the age of onset for a first headache is greater than 50 or less than 5. And previous headache. The best headache patient is a headache patient who's had the headaches in the past, because they can come in and they'll tell you what their typical, they'll kind of bring an auditory headache diary. This is what I get my headaches associated with my menses, associated with food, too much blood in my alcohol system type thing. Any of those things, they get the uh, alcohol on board. They get all this stuff. They make sure that we have our they'll walk you to it. It's like we learned in the advanced health assessment course, and just your common experience being at the bedside as nurses already. If you listen to the person, they can diagnose themselves majority of the time. You're just making sure that the symptoms fit, and we're ruling in or ruling out other stuff. But one of the big key questions to ask as far as history, has there been an acute change from a previous headache? So what makes this headache different? And they'll tell you. Secondary headaches. So for meningitis, think of the knuckle rigidity. Whereas intracranial hemorrhage, you can also have that knuckle rigidity, but you won't have the fever. And we talked about this earlier. You may need a lumbar puncture to confirm if the CAT scan is negative. More reassuring and negative information as you go out to take care of loved ones and go into the clinical setting. A brain tumor, it's not a common cause of headache. Like remember we said about only a third will show up with that as being the issue. Brain tumor, they'll have an intermittent, deep, dull aching, moderate intensity, nausea, vomiting. Temporal arteritis. So it's an inflammatory disorder of the arteries, also known as giant cell arteritis, and most common in the elderly. Left untreated can cause blindness. And the treatment, of course, for this is biopsy and steroids. And has anyone ever seen it or taken care of somebody who's had a temporal biopsy? It's actually quite interesting. Our surgical colleagues love it because it's bread and butter. They actually go in, they typically get max sedation. They will make a tiny incision. The surgeon goes in and clips part of the temporal artery, then oversews it, and then they send that to pathology. The treatment is steroids, and then glaucoma. You know, people can have a headache and then they have the nausea vomiting. The key feature here is that the eye is often red with a fixed, moderately dilated pupil. But let's spend a little bit of time because I've kind of acknowledged the elephant in the room when I talked about the CAT scan and the lumbar puncture. But let's talk about it a little bit further. In the terms of intracranial hemorrhage, if the hemorrhage is small or below the foramen magnum, your CAT scan of the head can still be normal. And that's why a small percentage of the population will have a normal CAT scan but have a hemorrhagic tap. Therefore, lumbar puncture may be required to definitively diagnose subarachnoid hemorrhage. Now, how do we know that this is a subarachnoid hemorrhage? The lumbar puncture in the patient who has a subarachnoid hemorrhage will have a high opening pressure and red blood cells that do not clear from one tube to the other. And they also can get xanthochromia, which can be present. And this is a result of the hemoglobin degradation. And what that tells us is that the blood has been in the CSF fluid for at least 2 hours. When we talk about the brain tumor, an intermittent deep or dull aching of moderate intensity, which will worsen with exertion or change in position and can be associated with nausea and vomiting. Vomiting that precedes the appearance of headache by weeks is highly characteristic of a posterior fossa brain tumor. And then when we talk about the temporal arteritis, it's a common disorder. The annual incident rate is 77 individuals per 100,000 over the age of 50. The average age of onset is 70 years of age, and women account for 2/3 of the cases. The reason I kind of belabor this point is that about half of those patients with untreated TA will actually develop blindness. So how do we treat it? First line analgesics, once again, opiates are not bad. They need to be used within reason, but from an opiate standpoint, we kind of got ourselves into this. Back in the 90s, Joint Commission came out and said, we're not doing enough to treat patients' pain. And we did early research and everyone got on the bandwagon that pain is what the person says it is. And then at the same time, pharma did a really good job lobbying us and selling to us that people aren't getting addicted, and that we're fine, and OxyContin is the latest and greatest. And so what happens is we've now dealing with this epidemic of opiate crisis. However, sometimes um, you may need that. So keep in mind it's not your first go-to, particularly for tension headaches, but it is something to consider. For tension headaches, NSAIDs, if within reason. So someone who's not your renal failure patient, someone who doesn't have profound hypertension, Tylenol. Caffeine has been shown to be beneficial. Fiorset. So is everybody familiar with Fiorset? So it's a medication, it's an oral medication. It has three agents. It has Tylenol, it has the butabitol, it has the caffeine, and it is a controlled substance. It's a class 4 or 5. It is a cousin to Fiorinol, and the difference between Fiorset and Fiorinol is the barbiturate, and no, actually, it's not the barbiturate. Fiorinol has aspirin instead of the acetaminophen. But they both have a barbiturate. They both have caffeine. The Fiorset shows it has Tylenol, and the Fiorinol has aspirin. Midrin is difficult to find, but Midrin is a great agent. Muscle relaxers. Ironically, Up to Date doesn't recommend one over the other. I have found that muscle relaxers tend to be quite helpful. I particularly like to use Robaxin because Robaxin is not as sedating. Another non-sedating one is Scalaxin. And then they get various degrees of sedation afterwards, particularly your diazepine, so your Valium, your baclofen, whatnot. And then, believe it or not, trigger point injections with or without steroids can certainly help. And I have, found that some people do better with the steroids, some people do not. It depends. My 2 cents on it is if we're already inserting a needle, leaving a little bit of steroid certainly shouldn't hurt, but you want to keep everything in perspective. When we go to migraine treatment, there's first and secondary lines of treatment. The first line is your anti-inflammatories, your antiemetics, and your triptans. There are many triptans out there, and sometimes it comes down to what the patient's wallet biopsy shows, what their insurance coverage allows. But when it comes to triptans, I tell people pick one, choose one, get to know that one, and then if you have to use the others, at least you have a working knowledge of one. Imitrex, Zomig, Maxalt are the common brand names. Secondary treatment, you have the antipsychotics, particularly droperidol and Haldol. Does everyone know what the slang name for droperidol is? Slap a nap. Because you give patients droperidol, give them 5 minutes, they'll be out. So that's the thing. So you also see it, especially, and the reason I bring it up, if you're in a hospitalist service, treating patients, and our colleagues down in the ER are having someone who they're trying to regulate behavior, they will oftentimes give them droperidol. And then it is a double-edged sword because it makes it for an easy admission for you because you're not able to get a history or physical on them. You can do a physical exam and that's about it because they're going to be sedated for some time. Others, it can really confound depending on why they're coming into the hospital. Droperidol is not readily available in all areas, and it actually wasn't available for a period of time. It's great for nausea. It's great for headaches, but just know that it has a certain degree of sedation. Haldol, what's the big thing with Haldol we want to be concerned about? QTC. So if you have a patient who has a QTC of 425, is that okay? Has everybody heard of a B52? So 50 of Benadryl, was it? Huh? Exactly. Um, so it's Benadryl, Ativan, and Haldol. It can actually also work with headaches. The ergotamines, steroids, so dexamethasone. Once again, the trigger point injections. And then, ironically, it looks barbaric, but it actually helps. Cephalopalatin ganglion block. Has anyone seen that? I have a video link on one of the slides that'll kind of show it. Oftentimes, what they will do is they will take topical lidocaine, put it on a 4-inch Q-tip, and then you put it into the nose, going to the palatine tonsil back here to numb it to block that. It's actually quite rewarding for the provider to do. It's typically tolerated well by the patient. I've done it once before where you actually give them nebulized lidocaine, so that kind of helps to numb that area, and then they'll do the block. Um, Narcotics here have no role in migraine headache treatment. However, I put the caveat, like I said before, unless it's incapacitating, and at which time you're probably admitting them. This next slide, I warn you, is busy. Um, but we really, factor on the red flags. So, are there systemic symptoms? Are there the secondary risk factors? And that's kind of hard to read, but it's actually on a prior slide. So, the ones who have a malignancy, you're concerned about HIV, pregnancy, anticoagulation. Are there abnormal signs or systemic neurologic symptoms? The onset, the suddenness, abruptness of it, the age. So greater than 50, less than 5, or there's a significant pattern change. And the best way to remember that is through the mnemonic SNOOP, SNOPP. And then this slide basically shows you from a visual perspective out of clinical pain medicine how to address the headache. For cluster, you have oxygen, you have the triptans, the ergots, and then this ganglion block. So I think it's worth watching. Hold on a second. Uh, have you guys gone to that next slide where it has the hyperlink for the block? So if you go there, because it's not wanting to, and you click on it. Okay, let's see what we got here. Let's. I like bupivacaine versus lidocaine, but because bupivacaine typically is going to last a little bit longer. So you do it until you meet resistance, and then you leave it in for 5 to 10 minutes. So for secondary headaches, we want to treat the cause. And that's the basic thing for the secondary headache. So it's almost like PEA, whatever brought them into that PEA arrest. So hopefully we'll reverse it if you treat the cause. Same thing with the secondary headache. It's treat the underlying cause, and you should see significant improvement. Um, let's get into delirium. I know that this is a new topic for everyone. No one has taken care of anybody who's had delirium in the past. Um, it's frustrating from the nurse who is managing the patient, because if you're in the ICU, you typically have two patients, and if you're most like ICU nurses, once the patient can use the call bell, it's time for them to go to the floor. If you're in the ER, it's a busy per day and night. You have 4 or 5 patients. Trying to keep the person in bed and oriented and whatnot can really slow you down. But unfortunately, as frustrating as it is for the nurse at the bedside, it's also frustrating and troublesome for the provider. And it's also, more importantly, devastating for the patient. And so there are at least two types of delirium. There's the hyperactive, and so this is the one who has that hallucinations, they're agitated, that constant fight or flight syndrome. The person who has profound alcoholism, they go into DTs. On the flip side, you can have the hypoactive delirium. So those are the ones who are quiet, they're withdrawn, they're really apathetic, and they've got the psychomotor slowing. So the opiate intoxication. Um, so if you have someone, you get the call as the provider that the patient is not easily arousable. One of the things on your differential should be, is this a hypoactive delirium? Common causes, um, fluid electrolyte disturbances, particularly hyponatremia and hypernatremia. Infections. We've all taken care of the little old lady who comes into the ER who's sent in from their facility because they don't act right. How many times have they had a urinary tract infection or a respiratory infection? Also, keep in mind that skin and soft tissue infections can cause delirium. Drug toxicity, metabolic disorders. Now, this kind of comes up from a practical standpoint. If you're writing a note and you write, as say, your number one diagnosis, altered mental status, oftentimes you won't be reimbursed, or if you are reimbursed, you're reimbursed very low. The CMS in vogue term, the one that your CDS folks are looking at, is metabolic encephalopathy or acute encephalopathy, secondary to toxic, secondary to metabolic issues. So your metabolic is going to be the hypoglycemia, your hypercalcemia, your uremia, and your liver failure patients. And then, of course, if you have people who have low perfusion states, so if they're in shock or the heart failure, and then, of course, withdrawal from alcohol and sedatives. Um, there are multiple different assessment methods for doing um, delirium. I like the CAM method because it's simple, it's relatively short and straightforward. So the acute onset and fluctuating course, inattention, disorganized thinking, and altered level of consciousness. The conditions noted most commonly in prospective studies of this disorder included in the medical and surgical settings, the CAM has a sensitivity of 94 to 100% and a specificity of 90 to 95%. It's become the standard screening device in clinical studies for delirium, both through the ER, the hospital, and your long-term care. It takes about 5 minutes to administer. And it has a review of 11 bedside instruments used to identify the presence of delirium, concluded that the best evidence supported the use of using the CAM. The CAM questions, did the patient have difficulty focusing attention as evidenced by 3 or more incorrect hand squeezes? So if you say to the patient, I'm going to read you a series of 10 letters, and whenever you hear the letter A, squeeze my hand. And if they're not doing that, that raises suspicion. And failing to squeeze the nurse's hand on letter A and then also squeezing it on any other letter than A. Number 3, these are simple, straightforward questions, but even dealing with a concussion, I have to stop and think, what's the answer? Will a stone float on water? No, but they may say yes. Are there fish in the sea? Does 1 pound weigh more than 2 pounds? And can you use a hammer to pound a nail? And so oftentimes what you'll particularly find is those who are more demented than delirious, it's almost as if the demented patient knows that they're demented, so they will try to be coy and say, oh, why are you asking me those questions? Or, I don't know. Or whereas delirious, they don't know if they're a horse or a hoofback. And then altered level of consciousness, is the patient's LOC anything other than alert? So, alert, they're fully aware of the environment, they interact appropriately. If they're vigilant, they're hyper alert, they're oversensitive to their environment, they're lethargic, stupor, coma. And then for those in the critical care arena, a RASS score of anything other than 0 at the time of assessment is concerning. Initial evaluation, you're called to the bedside to see the patient who is the nurse is noting delirium, history and physical exam, CBC, have they had recent labs? We're screening to see if there's any reversible causes. Is there an infection? A UA, UC. I don't know about your organization, but at Regions, it's getting pretty hard to get a UA on a patient. We had an over incidence of false UTIs, and our UTI scores were off the roof. And so now you have to have legitimate reason. And so as the practicing nurse practitioner, you often get a call, they have sediment in their urine. Is that a UTI? They have foul smelling urine. And so there's a lot of reorganization, reworking, retraining that's going on. But certainly think, is there systemic infection going on? Drug screen, that lumbar puncture after imaging, and then EEG to rule out if there is a clinical or a subclinical seizure going on. And then the second tier evaluation, checking vitamin levels, endocrine workup, ammonia, autoimmune workup, infectious serologies. The tenets, the take-home message, if you're, perhaps to see this on exam, avoid the known causes or aggravations, identify or treat the underlying acute illness, provide supportive and restorative care, and then protecting the patient and the environment. We're back to our friend, the Haldol. So 2.2 to 5 milligrams every 4 to 8 hours is needed. Keeping in mind that QTC prolongation can occur with cumulative doses greater than or equal to 35 milligrams. And torsades has been noticed with single dose is greater than 20 milligrams. Correct. And I think it's, yep. And as nurse practitioners, we're caught in both worlds. So so what would we do? What would you do? What would you recommend? Absolutely. So you can do other things other than Haldol. I'll be honest with you, I don't use Haldol as much as I once did. I use more Seroquel and I use more what's the other one? Seroquel and Zyprexa. Um, so keep in mind, and things are constantly changing. And I think that you point out a really good point that we're really not treating. And the other thing they'll often ask for is the benzodiazepines. Benzodiazepines will make the delirium worse, but I think it's important that we note that we're treating the behaviors, and we're trying to keep the patient safe. And I mean, it just seems to be Murphy's law. The um, staffing will send up, no offense, but the 4 foot, 95 pound nursing student who's as the 1-to-1 for a 456-foot-5 guy. Or and so while I mean those are real things as nurse practitioners we have to deal with because we're nurses first and foremost, but we're also healthcare, we're prescribers, and so it's delicate, balancing that delicate scope. So if you do use the Haldol, 2 to 10 milligrams, you can repeat a bolus dose every 15 to 30 minutes until calm, and then administer 25%. So I like this because it says, okay, get them under control and then back off. So this speaks to a lot of what the studies have shown too. Monitor the EKG and the QTC interval. As a provider, you will most oftentimes get a call from our pharmacy colleagues. They mean well, they're trying to help, but they'll say, hey, we are concerned about the QTC. And then like, and my ultimate response is, I appreciate it. I am too. I'm watching it, but we got to get the patient under control. So keep in mind that it's the QTC prolongation can occur with the cumulative doses greater than 35 milligrams, and torsades de points can have reported with single doses greater than 20 milligrams. I have never given anybody that much, but Seroquel, I like Seroquel. You can do 25 milligrams twice daily, and then you increase it 25 to 50 milligrams 2 to 3 times a day on the second or third day. Our target dose is 300 to 400 milligrams in 2 to 3 uh, divided doses by day 4. And the usual maintenance range is 300 to 800 milligrams a day. Hence, elderly patients usually require 50 to 200 milligrams a day of immediate release tabs or 50 milligrams of extended release tabs with a slow titration schedule. So like everything else with our elderly, start low, go slow. And then increase immediate release dose by 25 to 50 milligrams a day, or the extended release by 50 milligrams a day to an effective dose based on, once again, the clinical response and tolerability. Dementia. Our book both is defined both Harrison's and Barkley. Barkley says this is a key feature. Dementia consists of intact arousal state, but impairment of memory, intellect, and personality. Harrison's has an acquired deterioration in the cognitive functioning that impairs the successful performance of activities of daily living. Alzheimer's disease, 60 to 80% of dementias are related to Alzheimer's disease, but keep in the back of your mind that not every dementia is Alzheimer's. The vast majority are. The multi-infarct dementia, alcoholism, the Wernicke's encephalopathy. There's a lot of literature now, especially out in sepsis literature, and of the role of thiamine and vitamin C. High dose thiamine in your person who you're concerned about Wernicke's encephalopathy has been promising. Parkinson's disease can lead to dementia, normal pressure hydrocephalus, and then the other lower hanging fruits, your pernicious anemia, your hypothyroidism, and your neurosyphilis. In terms of dementia, the highest risk factor for dementia is age. At age 85, the average person is able to learn and recall approximately one half the number of items, so the words on a list, that he or she could at an earlier age. When you're working up dementia, the American Academy of Neurology recommends checking a thyroid, a vitamin B12, and then screening CT or MRI as you're able to rule out other organic causes. Historically, we've used the mini mental status exam. A lot of organizations have gone to the MoCA, or the Montreal Cognitive Assessment, and some are using the SLUM, so the St. Louis University score. I tell people use whatever your primary agency uses, get comfortable with it. The downfall of the MMSE is that it's a screening tool and you'll need further workup if it has any positive results. And really, you should have an 8th grade education and fluency in English to be able to use the MMSE, whereas MoCA, and how many people are using the MoCA at their organization? Okay. Have everyone seen what the MoCA looks like? So the MoCA is actually quite nice. It's user friendly. I will put a caveat that one of the reasons a lot of people went to MoCA versus MMSE and some other stuff was because of copyright and availability. And MoCA has now come back and said, I think it's by 2020, 2021, you'll need to be a registered user in order to be able to use it. And their claim is that there has been some litigation involved where families have come back and said the person who was administering the MoCA exam was not qualified, and that creates a challenge. Being, somewhat sarcastically, how much of this is financial gain versus how much of this is true litigation. But the take-home message is these are all screening tools. I like MoCA because it is easy to administer, and it's been shown to be reliable. Nice thing about MoCA as well is it's available in different languages. But regardless, at the end of the day, use what you feel. And so has anyone worked through the mini mental status exam? It's going to look at orientation, registration, so asking them what the objects are, and repeat attention and calculation, recall, language. So you're assessing the different executive functional areas of the brain. Fulstein et al. Developed this in 75, so now at 44 years, and it's had good reliability and validity. Any score greater than 23 to 24 out of the 30 indicates a normal cognition. And then it's broken down into categories. So 19 to 23, there's mild cognitive impairment. Moderate is 10 to 18, and a score of 9 or less indicates severe. The DMSE 4 criteria for dementia, so from our psychiatric colleagues: memory impairment, at least 2 of the following: problems with aphasia, apraxia, agnosia, disturbances in executive functioning. Disturbance significantly interferes with work, social activities, or relationships. And this is oftentimes the key point here. And the disturbance does not occur exclusively during the delirium. So delirium resolves, dementia doesn't. And so when we talk about like the aphasia, the loss of the ability to understand or express the speech, so it can be expressive aphasia or it can be receptive aphasia. Apraxia is the inability to perform previously learned purposeful movements or to use objects purposefully improperly. And then agnosia is the loss of the comprehension of auditory, visual, or other sensations, although the sensory sphere is intact. So they're unable to recognize objects, shapes, persons, sounds, smells, and so forth. Goal for dementia treatment is improve the cognitive function, reduce behavioral, psychological symptoms, and like everything else, improve quality of life. We talk about different treatment options. Aricept, the cholinesterase inhibitor, is basically there's more acetylcholine available to the brain, which is low in people with Alzheimer's dementia. Other drugs include Zyprexa, Seroquel, Risperidol, and Geodon. When we talk about the cholinesterase inhibitors, the Aricept 5 to 10 milligrams at bedtime is typically well tolerated with convenient dosing, and therefore it's the drug of choice. More recent drugs include Exelon, which is rivastigmine, so 1.5 milligrams twice a day, and you uptitrate that. And then there's NMDA receptor or N-methyl deaspartate receptor antagonist, so Namenda, and this prevents the progression. And that's the key use of that is it prevents progression, 7 milligrams daily, and you uptitrate. And then once again, the aggressive behaviors, kind of what we talked about earlier, the antipsychotics typically used are before you. If you were to, a good slide to look for keeping delirium and dementia separate. Delirium is sudden, dementia is gradual. Delirium can occur at any age. Dementia is typically greater than 60. The causes are vastly different. And the features for delirium, the inability to pay attention is one of the hallmarks, but then for dementia is that clear state of consciousness. So they'll have the distant past memory intact, but they don't know what they had for lunch. They may not remember who you are or what's going on. We'll go from there. Does everyone want to take a stand-up break, take a 5-minute break, and then and I'll try to check in with Sally to see if there's any wiggle room there too, okay? So let's talk about seizures. Every seizure is not necessarily pathologic, but there is a lot of epilepsy out there. There are sometimes seizures are unknown. It can be caused from acidosis, electrolyte disorders, hypoglycemia, hypoxia, alcohol intoxication, alcohol withdrawal, barbiturates, benzodiazepine withdrawal, you name it. That's one of the reasons why seizures are scary, but they don't necessarily need to be. Also, think about CNS infections, trauma, epilepsy, and then non-compliance with medications and space-occupying lesions. So when I'm looking at a patient who has an issue of seizure, in my mind, I immediately ask myself, is this non-epileptic seizure activity or is this epileptic seizure activity? Thorough history from the patient, which is often challenging, but the family and the observers of the event will often lead you to the answer. EEG. Now, does every first-time seizure need to be admitted to the hospital? So how many people think by a show of hands, yes? How many say no? Okay, good. So once again, evaluating the patient. Oftentimes you can get an EEG as an outpatient, and depending on where you are, it may be more timely to do it that way. And then sometimes we do admit patients for a 24-hour video EEG to document their activity, CAT scan or MRI. And at our organization, we typically do both a CAT scan to rule out presence of lesions and whatnot, and then the MRI looking for presence of stroke or if there's other activity going on. Lumbar puncture, and then your conglomerate of labs. So CBC, comprehensive metabolic panel, your troponemia or your VDRL, depending on what organization you're at, magnesium, calcium. Then we get into further in the weeds at ANA, sed rate, blood gases, depending on how profoundly ill they are, a UA, and a drug screen. One of there is some literature to suggest if you're concerned about is this a truly epileptic activity versus a non-epileptic seizure, sometimes checking the procalcitonin because that will be elevated. The problem is you need to do it within the first hour. And how many times have we found getting labs back from lab within the first hour is possible in the ER, or presenting within that golden hour. The other thing is, it may help and may not. How many people have heard of checking a lactate for a seizure? So I wouldn't because it's going to be elevated. So, but sometimes, we pull the trigger and we order a whole slew of labs and we're trying to be helpful, but at the same time, it's not always helpful. If you were to check a lactate, it most likely is going to be elevated. The serum prolactin, which we talked about before, rises 2 to 3 times above normal for 10 to 60 minutes following most seizures. So that's why you want to, if you're going to order it, you need to do it within that window. Wow. And are they awake for the so there's a nurse at the bedside for, wow. Wow. And as a nurse, is that a cush assignment or is that a challenging assignment? Wow. That's right. Huh. Wow. That's pretty impressive. So supportive care. So most seizures are self-limiting. Your guys' cases are somewhat the exception. Um, so maintaining the open airway, protect the patient from injury, administer oxygen if the patient's cyanotic, How many have heard the horror stories or been around long enough that we used to use the tongue blades? You used to take a tongue blade, wrap it in tape, and then tape it to the head of the bed. The thought was that the patient was seizing, you give it to them to bite on. The reality of it actually causes more problems um, because they can cause the tongue to occlude the airway or teeth to break off, causing a possible partial obstruction. IV fluids and primarily isotonic. You don't want to give anything that's hypotonic. And then perform EKG, baseline labs, baseline physical exam. And go from there. So supportive airway, protect the environment from the environment, oxygen, do not force the airways, monitor. Remember, oftentimes this is self-limiting. Oftentimes the treatment, mainstay benzodiazepines, many different routes, doses, phosphenotoin, Cerebex is the brand name for that. Valproic acid, 20 to 40 milligrams per kilogram IV. Keppra, typically anywhere from 1 to 1.5, or I'm sorry, 100 to 150 milligrams per kilogram. So they're getting 1 to 3 grams IV. And then sometimes we're having to intubate the patient. So propofol is a great agent to use. And ketamine for refractory status. Are you guys using ketamine? More Versed? So yeah, so that's the thing. Now let's talk about for a moment as a kind of a segue, your alcoholic withdrawal who has to be intubated. How many people are you using phenobarb? Okay. How many people are using the traditional Ativan Valium combination? The thing with and how many people are using Precedex? Hmm. And so the problem with the Precedex is it controls the behavior, but it doesn't take care of the seizure. So then you also have to give scheduled benzodiazepines. Whereas the propofol will often help with suppressing seizure activity, the benzodiazepines will. So that's the thing that you're having to keep in the back of your mind. Um, the big thing is when you're managing these folks, don't abruptly withdraw their anti-epileptic meds from the patients. Aggressive treatment is needed for seizures lasting more than 10 minutes. Most seizures are self-limiting. Instruct them not to drive. And in the state of Minnesota, we are not obligated to report. We're a self-reporting state. But this link here at one point was taking us. It would take you to the form to report. Anybody can report. The patient can report. Should report. But family members and the thing you got to think about this too is you're potentially you're not only balancing the safety aspect of it, but then this gets really touchy because you're also not, potentially impacting their ability to be independent. So from a providing perspective, I would say instruct them not to drive, get them to neurology, get them to primary care, and they can deal with the consequences. But you are not, as a provider at this time, are not required to report. And that's one question that comes up often. Meningitis. So it's inflammation of the pia mater and the arachnoid of the brain and the spinal cord. It's either bacterial or viral. Bacterial, the purulent infection within the subarachnoid space, and it was oftentimes exudative. And then for viral, it's filled with lymphocytes, but not the exudative forms. The history and physical exam, they're going to have fever, knuckle rigidity, altered sensorium, chills, toxic appearance, photophobia, severe headache. You can have the exaggerated deep tendon reflexes, seizures, sensory loss. Has anyone seen the petechia or the purpura? I've got a slide coming up here next that'll show that. And then Brzezinski and Krennig sign. From a bacterial meningitis perspective, does anyone know what the most common cause is? Strep. Neisseria is seen in crowded areas, so military barracks, dormitories, whatnot. H. influenza. Vaccine has greatly reduced the number of cases in the U.S. And children most at risk are those who are in the daycare and children who do not have access to the vaccine. But oftentimes, when you go in the military, it's given to you complimentary as part of your indoctrination package. And you'll often see students who are going off to universities being required to have the meningococcal vaccine. This is the purpura and the petechiae that you see with bacterial meningitis. I always have to look this up. It's one of those things you memorize for a test, and then when it comes to real world, you do it, but then what do we call it? So the Brzezinski sign is you flex their head and you move their knee and you elicit the pain. And then the Krennig sign here, patients with meningitis, it will trigger pain and spasm of the hamstring muscles caused by inflammation of the meninges and the spinal nerves. And the way I try to remember this is B for B is the beginning of the alphabet, and we're moving the head up and associating those two. So however you work it out to remember, but this is the Brzezinski's neck sign, and this is Krenig's sign. When it comes to the medical decision making and evaluating folks for bacterial meningitis, CBC, 2 sets of blood cultures, lumbar puncture remains the standard diagnostic test of choice. Should be done as soon as possible. Should not delay empiric antibiotics. So get it done, but it should not delay the empiric antibiotics. And it's contraindicated in people who've got focal neurodeficits, so papilledema, or if you have space occupying lesions such as hematoma, abscesses, whatnot. Bacterial meningitis checkpoint for you guys. We had talked about this earlier. Do I have to do a head CT prior to an LP? If they're immunocompromised, HIV, immunosuppressive therapy, AMD drugs, solid or organ, or a hematopoietic stem cell transplant, if they have a history of a CNS disease, a mass lesion, stroke, focal infection, new onset of seizure within the last week from presentation, papillable edema, abnormal level of consciousness, and focal neurodeficits, get a CT of your head prior to doing the LP. When we looked at the papillable edema, on your left, this is shows optic nerve edema and swelling here. And then on the right is, I'm sorry, on your right is the optic nerve edema. And you can see that halo effect. And then on the left is the normal optic nerve that has a 0.2 cupping. How many people have done a lumbar puncture in clinical or bedside as assist? Okay. Let's see what we got here. What? Let's see.
So if you can go into edit hyperlink and open that and copy the.
Yeah, it's not my. It's okay. Here we So it's an informed consent process. You can either have them in a lateral decubitus position or upright. You'll see them identifying the landmarks. And of course, they make it, they find appropriately so the person who's most accessible. Oftentimes, we end up sending these folks to IR. Right. They're good. So the bevel up, you advance that needle slowly, and you'll feel a popping sensation. And this is where the term spinal tap comes from. You're removing that stylet intermittently. So that would be considered a clear tap. And then I would protect those specimen vials with your life. This is not something that you would give to the huck to send down to the lab. I would walk them down myself. What's that? So the specimens, so glucose, protein, cell count, culture, gram stain, and then other indicated tests. So you bring up a good point about a blood patch. Is everyone familiar with the concept of a blood patch? So what is one of the most common common complications or side effects to having a lumbar puncture headache? So does everybody know what they do with the blood patch? You want to walk us through it? Have you done it, or have you seen it done? So yeah, so you often find these patients coming to the ER after they've had a lumbar puncture. Oftentimes anesthesia will do it. IR can also do it. The reason anesthesia is because oftentimes the people we typically see are those who are postpartum. They had an epidural, whatnot. They draw some blood and they actually do a blood patch. And then basically it's patching a micro um, tear. So that's one of the reasons why, bed rest and getting them back in will help, or mobilization after um, bed rest will help. Let's see. Lumbar punctures, they're one that's a test that or a procedure you want to do, but you want to do it if you're doing procedure and procedure driven with someone who can spend a lot of time and walk you through it. Typical CSF findings in the presence of infection. Pay attention to the glucose and the protein, as well as the white blood cell count. Most common, glucose less than 10, bacterial meningitis. Although sometimes 10 to 40 is also there. Protein, when you're getting 50 to 300, we're thinking things outside of bacterial. Then the big question is, what is the white blood cell? Greater than 1,000, bacterial meningitis. 100 to 1,000 could either be bacterial or viral or TB. 5 to 100 is early bacterial, viral meningitis, neurocephalus, or TB. And so this is one of the reasons why we look at things as a complete picture. A gram-positive diplococci suggests a pneumococcal infection. Gram-negative suggests the meningococcal infection. And if you have pleomorphic gram-negative, H. influenza, and then gram-positive rods suggest listerial infection. In fact, in treatment, treatment goal 60 minutes of hitting the ER doors, treat the most common bugs, the strep and the Neisseria. Antibiotics, depending on your organization, cefotaxime or Rocephin. And the Rocephin dosing is 2 grams Q12, vancomycin, and then add ampicillin 2 grams if you're concerned about listeria. The problems with delayed treatment in a prospective study of 156 patients with pneumococcal meningitis, a delay in antibiotic treatment of more than 3 hours after hospital admission was a strong and independent risk factor for mortality. And our key factors in the empiric treatment intent, these drugs need to be bactericidal, not bacterial static. And these drugs have to be able to penetrate the CSF. Other considerations, once again, ampicillin if listeria is suspected, acyclovir as HSV is most common viral differential. We're in the midst of tick season, so doxy. And then there is the use of steroids. And once again, being a prudent antimicrobial steward, tailor the antibiotics as cultures return. Early intravenous administration of glucocorticosteroids, so the dexamethasone, is evaluated as adjunctive therapy in an attempt to diminish the rate of hearing loss, other neurologic complications, and mortality. This is based on clinical data from Europe. The main indication for dexamethasone therapy in adults is known or suspected pneumococcal meningitis. The recommendations for antimicrobial therapy for purulent meningitis based on age, so most common bacterial pathogen, and that's middle column. So once again, if you're looking about listeria, associate that with ampicillin, plus or minus cephalosporin or aminoglycoside. Strep, vancomycin plus the third generation. And then vancomycin, if you're really worried, especially over the age over 50, strep, Neisseria, listeria, and aerobic gram-negative bacilli. We're typically hitting them with 3 agents. We're getting them vanc, we're giving ampicillin, and then typically Rocephin 2 grams IV Q12. Viral meningitis is much more benign. It's caused by viruses such as mumps, the enterovirus, influenza, varicella, HSV, and EBV and HIV is supportive care. Antivirals do play a role. Acyclovir 10 milligram per kilogram Q8 hours. And if we're really worried about CMV, cytomegalovirus, the CNS infection, ganciclovir 5 milligrams per kilogram Q12 hours. I'll be honest with you, at this point, ID is oftentimes guiding the conversation. And this would be certainly someone that I would get ID involved in. Encephalitis, an acute inflammation of the brain. It's usually caused by a viral or other infection and appears 2 to 12 days post initial infection. Um, Most common cause in the U.S. is the West Nile. Other causes include HSV, varicella, tick and bug bites, toxoplasmosis, and there is some concern about influenza. So when dealing with encephalitis, history, obtain a thorough history, signs and symptoms, looking at lethargy, fever, nystagmus, nausea, vomiting, knuckle rigidity, headache, if they're ataxic, dysphagia, hemiparesis, the same things we saw with some of the headache stuff going on, stupor, confusion, seizures, coma, and then looking for medical decision making, checking the CBC, comprehensive panel, ammonia level, CT, MRI, and then checking the IgM antibodies. Treatment is supportive, oxygen, IV fluid. You want to prevent secondary infections. If there are seizures, treating the seizures, and then targeted treatment if you're able to identify the cause. Guillain-Barré. Studies have shown that a high proportion of patients with Guillain-Barré have um, is it Clostridium jejuni in their stools at the time of onset of their neurologic symptoms. No, not Clostridium. It's Campylobacter. Sorry, and Campylobacter jejuni is a zoonotic disease found usually in water contaminated by animals or by drinking unpasteurized milk, and it's one of the most common causes of diarrhea in the world. So once again, it's very important to gather a good history to determine if the patient has risk factors for having this infection. Have they traveled? Where have they traveled? Um, it's usually preceded by a prior illness. The thing about Guillain-Barré, it's ascending weakness, so it's progressive weakness in the lower extremities, and reflexia, so the loss of reflexes, is universal. Muscle weakness begins in the legs, progresses to the arms, the face, and the oral pharynx. It can progress to total motor paralysis and death from respiratory failure. Interestingly enough, they'll develop the stocking distribution of the sensory loss. And then you have the autonomic dysfunction, and this is where they get into trouble. Um, they have the erythema, they have blood pressure fluctuations, they have pupillary changes. Oftentimes, they require ventilator support. The nice thing is, if you treat it and diagnose it early, it's oftentimes treatable. They have up to a year-long recovery, but they can do let's see. Um, so the treatment is history and physical. Typical labs to rule the differential. Diagnosis is confirmed, hint by LP. So CSF will show normal WBCs and high protein, and the EMG will show abnormalities. Supportive care, anticipate the respiratory support. So oftentimes these folks will need to be intubated, specifically if it's long pronounced. IVIG, and the problem is now we have an IVIG shortage. It'll be interesting sidebar commentary to see what happens in the upcoming months with the trade talks with China. The majority of our medications are tied up in China and they come from China, and to see what kind of impact that will have on us. What's that? Yeah, it's but IVIG when available requires a dedicated line, a high dose, and you use and it promotes the remyelination and the demyelinating disease. Um, they also have plasmapheresis and your treatment of choice in those who are acutely ill. Ideally, plasma exchange or plasmapheresis should be done within 7 days after onset. It's very beneficial in preventing the paralytic complications. Anecdotally, patients have reported improved more quickly. They can be weaned from the ventilator earlier and can ambulate earlier. And it's thought that the plasmapheresis, so they're doing the plasma exchange, you remove the circulating antibodies, the complement and soluble biological response modifiers, and then it becomes more able to treat progression of weakness, the anticipated course for up to 2 weeks. It plateaus for 4 to 6 weeks, and then they get gradual improvement. Mortality, while is low, is still present at 5%. However, mortality will go up to 20% if the patient becomes ventilator dependent. And we're in the home stretch. Myasthenia gravis. Has anyone seen anybody or taken care of anybody with myasthenia gravis? It's pretty cool. Not for the patient, but for the provider, because it's one of those things you can easily identify and treat. And then it also helps, and they typically have good outcomes. Most common disorder of neuromuscular transmission, so the acetylcholine, it activates the muscles, the major nerve transmitter, and bless you. And what's happening is the antibodies are attacking the acetylcholine receptors. What you have that's different with myasthenia gravis versus Guillain-Barré is you have fluctuating skeletal muscle weakness and true contractural weakness, and it's not that ascending pattern. Most common manifestation is ocular weakness, and they get that ptosis. But bulbar, limb, and respiratory muscles are also affected. The problem with myasthenia gravis is that the myasthenic crisis is sudden and severe in onset, and respiratory muscles are usually involved. And so this is somebody that we would typically check a NIF or negative inspiratory force on. And this is somebody that I would admit to the ICU because you want close monitoring. If you have no ICU beds, at least a progressive care because they may need ventilator support. And then the ptosis, you have the drooping of the eyelid here. The myasthenia gravis. Steve, were you with me when I had the patient? I had a student with me and got call 67-year-old gentleman who had some ptosis, who had some weakness. Everything was coming back. And coming back fine or equivocal. And so they were going just to admit for cellular observations. It's kind of like what back in the 90s and the early 2000s, Romy Modi diagnoses where patients were ruled out MI ruled out. So the reason for admission was rule out MI, discharge diagnosis, or MI ruled out. Same thing with myasthenia gravis. We're not sure what they're doing. We want to watch them, the watchful waiting. And I said, I think something's more going on. Let's just come down and see him. We went down to the ER and saw the patient, and we did an ice pack test. And the ice pack test, it's based on the principle the motor neuron transmission is increased at cooler muscle temperatures. So an ice pack is placed on the ice for 2 minutes, and then you assess the involvement of ptosis. And he ended up having myasthenia crisis. You can also do a tensilon test, and it prolongs the presence of acetylcholine in the neuromuscular junction and results in immediate increase in muscle strength in many of the affected muscles. And basically, what you do is you give increments of 2 milligrams every minute up to 10 milligrams. The problem with doing a tensilon or edgerotrophin test is that it can cause arrhythmias, and so cardiac monitoring is prudent. And then if they're elderly or they have a significant heart disease, not administering this. Acetylcholine receptor antibody test is confirmatory for myasthenia gravis, and repetitive nerve stimulation, along with single fiber EMG testing. It's if they get better. 1 second. Let's see if I have the. Yeah, better. They should be symmetric after. And let me see if I can show you because this will help. Let's see.
for nerve stimulation. I'm not sure.
Let me,
What do you use for a nerve stimulation?
oftentimes they'll use the needle. Yeah. And oftentimes the neurology is but this is really a cool.
Possible by fatiguing the muscle. And once you see the ptosis at its maximum droopiness, you ask the patient to apply simply a cube of ice to their eyelid for between 1 and 2 minutes. And analogous to a tensilon test, we hope that the eyelid will spring open. And then there's really no need for any other tests. We know it's nice. We can grab us and we can continue the treatment either acutely with immunoglobulin steroid or more long-term with other types of immunostimulants. While the tensilon test that works is definitive, the ice test is clearly less invasive. Why the ice test works to improve ptosis isn't entirely clear. It is suspected that perhaps the eyelid is a very much overused muscle or a frequently used muscle, and by cooling it down, you might be reducing its metabolic rate and thus reducing the amount of acetylcholine required, and thus reversing the block given by the anti-acetylcholine receptor or anti-muscle antibody is one theory. But I don't think, as far as I'm aware, it's not clearly known. Okay, do you want to take it off then? Look at my finger. So after the ice test, you can see the instant response, and you can take the patient there. Almost certainly it lands in there. Keep it in this one. Good. It's just no work. Yeah.
And the nice thing is this really does, it's kind of gratifying because it's it's high utility, low side effects. It's typically well tolerated, and they actually feel like they are giving. Yeah. Correct. So this is a good first line test. So if you, I mean, this would be the test that I would look at doing if I was working in a rural hospital. And are you looking to send a patient out? Or is it somebody that you can keep? This is what I would consider more confirmatory test, being the tensilon test. And
Jim is a previously healthy, active man. He underwent an uncomplicated heart bypass surgery a month ago. A few days after surgery, he began complaining of shortness of breath. Within a week, Jim was unable to walk and had difficulty swallowing food or liquid. His doctors could find neither a cause nor a treatment for his condition.
I mean, how many times have we
As
seen
Jim
that?
worsened, his doctors referred him to hospice for care of what they considered to be an incurable terminal illness. Jim is physically and emotionally exhausted, so short of breath that he will not let himself sleep for fear of never waking up. Jim's wife asked that he be transferred to another hospital to be evaluated by a neurologist. The neurologist suspects myasthenia gravis, a condition in which Jim's immune system has mysteriously begun attacking nerves and muscles throughout his body. This immune attack blocks the actions of acetylcholine, the chemical messenger that is released from nerve endings and crosses the neuromuscular junction to bind to muscle, which results in muscular contraction. Open your eyes as wide as you can open them. And give us a big smile. Okay? And say this for me. Massachusetts Fish Commission. Okay. Lift your arm up over your head for me, your left arm. Okay, don't let me push it down. Okay? Well, we'll see what we can do. All right. And I want to check your breathing here. That's not too bad. One finger knocks one arm down. I know. Well, we're hopefully going to fix that here. It used to be. Take a big breath in. In. Do it again. Okay, so you're getting about up to here. Less than 500. To test for myasthenia gravis, the neurologist is about to administer ergothonium or tensilon, which will temporarily increase the amount of acetylcholine available to Jim's muscles. If the diagnosis of myasthenia gravis is correct, we should see a significant improvement in Jim's strength. How are you feeling? Still seeing two? You're opening your eyes wider? Yeah. Smile. Smile. Say this. Massachusetts Fish Commission. Massachusetts Fish Commission. Okay. Take a big breath in here as much as you can. See that? Go all the way up to there. Do it again. Lift that arm up. Keep it up. You're a genius. Pretty amazing, huh? Yeah. Say it again, Massachusetts Fish Commission. Massachusetts Fish Commission. Squeeze your eyes tight. Keep them tight. Do that breathing thing again. Let's see, single. You know, one squirrel can find an acorn. Good. Thank you. You're welcome. Further lab testing confirmed very high levels of antibodies to several parts of the neuromuscular junction, consistent with the diagnosis of myasthenia gravis. Jim was treated with pyridostigmine or mestinon, a medicine similar to tensilon, but in a longer-acting pill form. Mestinon does not stop the immune attack on the nerve and muscle. It only helps to replace the resulting acetylcholine deficiency. After 6 months, Jim slowly took himself off of the medication. While those antibody levels remained very high, his symptoms completely resolved and have never returned. Jim's disease ended as mysteriously as it had begun.
I'm a big proponent for hospice when necessary, but the wife's advocating for her husband led to further diagnostic testing. So I show this for a couple reasons. One, to kind of drive home the point, always listen to the patient and their family. And two, we don't always need to use the latest and greatest MRI, CAT scan, the physical exam skills, the listening skills. I often tell people we have two greatest tools in our toolbox. We have 2 eyes and 2 ears to listen and hear, and 1 hand to write with. And we should do a lot less writing and more listening and more hearing what folks have to say. So that kind of wraps up myasthenia gravis. See if there's, yep. it typically, would go into remission, but then you are always, or you're more inclined at some point to have an exacerbation. Now, some people may never have another exacerbation. Other people may um, have it much more frequently. So oftentimes they will require chronic immunosuppression. And these aren't, lightweight drugs, glucocorticosteroids, Cellcept, cyclosporin, um, more the chronic side, the rapid, the plasmapheresis, the IVIG, even some role of the thymectomy will work. Um, so when you're talking about like medications, um, pyrostigmine, most widely used drug. A typical starting dose is 30 milligrams 3 times a day. When we talk about the plasmapheresis, it directly removes the acetylcholine receptor, so the AChR antibodies from the circulation. So it filters it out. Then clinical improvement with plasmapheresis roughly correlates with reduction in antibody levels. And so you can typically see it within days, but the benefit to this typically only lasts for 3 to 6 weeks. And so that's the reason. And the acetylcholine receptor antibodies will typically rebound if they're not given concurrent treatments such as glucocorticoids. And then the real refractory patients will go for a thymectomy, and the thymus is primarily involved with the processing and the maturation of the lymphocytes, and those become T lymphocytes upon release into the circulation. And up to 1/2 of patients with MG or myasthenia gravis have a thymoma, and patients who have the thymomas, they need to have the surgery. Those without, but sorry, those without do you guys do that at your organization, your facility? Have you guys seen that? And the neuro, oftentimes these patients go to the neuro ICU afterwards. Um, those who without but have the continued myasthenia gravis do better if they have a thymectomy if they're less than 60 due to the many years it takes to see the benefits. Um, and so if you don't have a thymoma but you have the myasthenia gravis and you're less than 60, it's a grade 2C recommendation. Um, but keep in mind for the thymectomy, it's not immediate treatment. It's going to take time, years to see the benefits. And so that's where are they going to live long enough to see the benefits? So that is it. That is neurology highlight, lowlights, what you would necessarily see most commonly out on the ward and in the ICU.